All right, everyone. I'm excited about today's episode. We have on Leslie Flannery. Did I pronounce your name right? I usually ask before we record. Yes,
Yes, that
okay,
is correct.
okay. Leslie Flannery, and we are going to talk about gestational diabetes. I have never done just an entire episode dedicated to it. And as a doula, I'm not like super well versed in this area. Actually, it was having a client last year that made me learn some more about it. And I knew some of like the typical things that like we'll get into a little bit later. But what I do know is that there's a lot of stigma and a lot of unknown. Like, even if you're diagnosed with it, it's just like, okay, here's the changes you make, but not really still knowing what it is or why you got it and how to move forward. So I'm super excited to have this episode with you. I would love to just kind of start out with you telling us a little bit about yourself and what got you into gestational diabetes coaching and being so passionate about sharing all of the information that you do.
Yeah, thanks for having me, first of all, because I do think that there's a lot of gaps with gestational diabetes. So I'm happy to come talk about it. And I am a mom myself of two boys. So, I've been through pregnancy, been through postpartum, and I've been a dietitian now for 10 years, which I cannot believe. And I started really in a WIC office, which is Women, Infants, and Children's, and dietitians help with nutrition education to breastfeeding, pregnant, and postpartum moms. And I just absolutely fell in love with working with women, I think, mainly because there is such a gap in nutrition education out there, especially coming from doctors' offices. And so I loved filling that gap. It was a little bit far drive for me, so I found a job here locally working with gestational diabetic women in a maternal fetal medicine doctor's office. And I have been working with gestational diabetic women for 5 years now. Decided that, in that office space, I loved, loved, loved helping people problem solve their blood sugars, but I only got to see them one time.
Hmm.
And that is just not enough for someone who's trying to manage blood sugars for like the last 2 months of their pregnancy because things change. So I decided that I could do this on my own. If I start my own private practice, I would be able to support women in the way that I think that they are looking for that, ongoing long-term support. So I started my business about 4 years ago and love it.
Yeah, that's awesome. Um, I felt that similarly when I was a doula, because for a while I was employed with a midwife group here at a hospital and I loved it. But I didn't get to like m develop a relationship with them. It was like
Mhm.
we'd maybe meet at a meet and greet and then I would just show up to their birth and be their doula. And I'm like, I really miss the getting to know you and what you're really looking for and how I can support you best in that personal relationship. It was a great experience, but I definitely missed like being able to go further or like in the way that you want to. So
Yes.
I resonate with what you're saying. So I just want to start with like the basics because, like I said, I don't know a ton about gestational diabetes. So let's just start with what does this mean? You got a diagnosis. So what does that mean?
So gestational diabetes, and it can be confusing because there's type 1 diabetes, type 2 diabetes, but gestational diabetes is its own unique thing. Essentially, it is insulin resistance diabetes in pregnancy. Just during gestation, just during pregnancy. So it's usually screened for in weeks 24 to 28, although there are some women who will be screened earlier if they have some other risk factors. But typically, end of second trimester, maybe very beginning of third trimester, as pregnancy hormones increase, causing blood sugars to increase. And then once you deliver the baby and deliver the placenta that's causing those high numbers, your gestational diabetes resolves itself. Now, it is good to be screened to make sure, in that postpartum phase that it wasn't underlying like prediabetes or type 2 diabetes, but gestational diabetes, true gestational diabetes is just diabetes in pregnancy.
Hmm. Yeah, it's so interesting that there are like different things that pop up in pregnancy that like as soon as you give birth go away.
Yeah.
You see that with a lot of risk things that pop up. Um, and and so it's I think that that's also where the stigma comes from a little bit is if it's just in your pregnancy, then it's not necessarily like a lifestyle thing, or not necessarily like, you know, what I'm trying to say, like it just popped up in your pregnancy. This isn't because you ate McDonald's every single day
Right.
leading up to it, because there are people who are extremely healthy that this happens to too. And but you get this diagnosis on you, and all of a sudden you're restricted in so many ways. But there can be like stigmas around that, that like, oh, you have gestational diabetes, you must not have taken care of yourself. So I'd love for you to like maybe speak to that a little bit.
Yeah, for sure. And we hear a lot of times like type 2 diabetes is diet and life. It can be brought on with diet and lifestyle
Right.
habits. And so we automatically assume that that is the case for gestational diabetes. And like you said, there are so many women. I was just talking about this on my Instagram yesterday that I've even personally worked with who don't eat in that way at all and end up with gestational diabetes. And on the flip side, there are women who eat that way and don't develop it. So
Right.
gestational diabetes is so nuanced. I mean, every single one of us has a different maybe set of risk factors, different health history, different hormone levels going on. So someone might just have strong placental hormones that cause a little bit more insulin resistance than somebody else who doesn't end up developing. But yes, a lot of times it is like that label of you must be unhealthy, you must have eaten a lot of sugar, you must not take good care of your health, those types of things. Or a lot of women just feel like it's their fault and that
Mm-hmm.
shame. And that can be really hard to come to terms with.
Mm-hmm. Yeah, I think that's very typical with, again, like a lot of the issues that arise. Um, so you kind of led into the next thing. So like what you've hinted to, like placenta, hormones, different things, like what actually causes it? And then what are some of the risk factors that could potentially cause you to have it?
Yeah, and I think there's still a lot of research being done with gestational diabetes because again, it can be so different from person to person. So the underlying similarity is that you have a placenta, and the placenta makes us more insulin resistant, all of us. And some women will go on to develop gestational diabetes, and some won't. So there, you can't necessarily pinpoint it to one certain cause, other than the fact that the placental hormones are making you more insulin resistant. They are making your blood sugars higher. Now, with that being said, if you have risk factors, and some of those would include having PCOS, polycystic ovarian syndrome, it comes along with insulin resistance. That's usually a characteristic of that. Then that additional insulin resistance in pregnancy with what you already have going on can then make it harder for blood sugar, so then can lead to a diagnosis. Or if you've had a previous pregnancy with gestational diabetes, it's more likely to develop it again. If you have a family history, so mom, dad, grandma, grandpa has type 2 diabetes, that might, it could, sometimes you can develop gestational diabetes with a family history, sometimes you don't, but it could indicate that there is a hereditary link to your insulin just being a little bit slower, like you having a little more insulin resistance just from
Mm-hmm.
family history. Um, One that gets thrown around a lot, which does also, I think, bring a lot of guilt and shame for women, is BMI. And
Mm-hmm.
so, in the nutrition world, I can't stand BMI
I know, same.
because it just looks at your weight to your height comparison. That's all it looks at. It doesn't tell us
Right.
anything else about your health except for comparing your weight and your height. So, really, what it is body fat percentage. So, more fat tissue makes us more insulin resistant.
Mm-hmm.
Now, there can be people in larger bodies that have less percentage of body fat. And there can be people in smaller bodies that have more percentage of body fat. So, I think that is a big stigma of like weight and BMI, but really it's
Right.
your body percentage that increases your risk. Um, Other risk factors, ethnicity, age, things like that. So if you have maybe a lot of these things, and then the placental hormones, probably more likely to end up with gestational diabetes. But again, there are some people that have these things that don't develop it, and there are some people that don't have any risk factors that develop it. So it's
Right.
just very nuanced.
Yeah, yeah. Um, so if it's kind of like linked to placenta, I've heard some research about how the sperm actually helps develop this placenta. So could it be like coming from the male partner's side versus you?
Yeah, I have heard that as well. I haven't dug as deep into that research, and I don't know if it has been studied with gestational diabetes specifically, but I would
Yeah.
be super interested to hear
Hmm.
what those findings would be. Um, because, yeah, I think that would be really interesting to know if dad has that family history of type
Yeah.
2, if that is then contributing to
Yeah.
mom's situation.
Yeah, I've heard some links with placenta, the male side, and preeclampsia, and even like people who
Mm.
have switched partners and like they had preeclampsia with two pregnancies with like their first husband, and then they had another pregnancy with, a subsequent partner and didn't have it. And I'm like, let's just blame them.
Yeah.
We take
I
so much blame and responsibility for so much.
Like, we need to share the load, right?
Right, right,
Yeah,
totally.
and I actually have heard that too with the differing partners. So I would love to see like a really large study done with that as far as gestational diabetes goes.
Right. I mean, but with like so many things hereditary too, it could come from like either side, or like you said, how a genetic factor could play a role into it. Um, so when they're doing the test, what exactly are they looking for?
So the standardized tests that at least we use here in the United States, most other countries use as well, are glucola drinks. So for the 1 hour screening, it's 50 grams of liquid sugar in the form of a drink. They'll have you come in to test your fasting, and then you drink that drink. And they want to make sure that that number fasting should be under 95, and the 1 hour number needs to be under 180. Now, with that being said, I've heard different women tell me that their labs or their providers are looking at different numbers,
Yeah.
but that's pretty standard. And then if that number, if you go high on either of those, the fasting or the 1 hour number, they're going to have you come back in for the 3 hour glucose tolerance test. And that will be your fasting. You drink a drink that's 100 grams of liquid deliciousness, liquid sugar. And then you test your blood sugar at 1 hour, 2 hour, and 3 hour. Well, the lab does. And for that, you want to be under 180 at 1 hour, under 155 at 2 hours, and under 140 at 3 hours. So, in my opinion, those drinks are not perfect. They are flawed. A lot of people are not sitting around drinking that much sugar at one time, but
Hmm.
we know that it is going to bring your blood sugars up higher. And so they're wanting to, what they're looking at, what those tests are looking at, is your insulin working efficiently to bring your blood sugars down after a high carbohydrate load?
Hmm. Yeah. Like you said, providers look for different things. So, because that's something that even a client of mine dealt with. Her number was below the threshold, but they still wanted her to like go for the 3 hour test, even though she was like below. And
Mm,
she's like, I'm not even like in the range, so I don't understand,
yeah,
like, and she like barely failed the 3 hour test. So it was like very frustrating when it's like, okay, is it this range or is it not? Like, do I have it? Do I not? Do I,
yeah,
like, I don't know. It's hard when some things aren't black and white
yes,
and everybody like practices it differently. And you see that in the birthing world a lot.
yeah.
So it's like, wait.
Yeah, it is very frustrating, especially on my end, where I work with women from all over the country internationally. And I would understand if different countries go by different guidelines, that's fine. But even in the United States, someone from New York to Florida to California could have completely different blood sugar goals, like when they're testing at home. And it drives me crazy. I'm like, where's the continuity of care? We have
Yeah.
research. Let's pick one guideline and like set all women to that standard instead of like, I'm over here, my fasting needs to be under 90. I'm over here, my fasting needs to be under 100. It's just, I don't like that. I wish it
Hmm.
was all the same for everybody.
Yeah. So now that we talked a little bit about what can cause it, um, is there anything we can do to prevent it? Like before we're trying to conceive or in the first trimester, or like leading up to that test, is there anything that we can do to try to prevent a positive gestational diabetes test?
Yeah, it's such a good question. And again, kind of like what causes gestational diabetes, I think the prevention of it is muddy. It's not a black and white kind of answer. It's going to depend on each person. Because, we could have someone, let's say, for instance, who consistency is a really big part of keeping blood sugars managed. So I have worked with some women who, for whatever the reason is, are not eating very much throughout the day, or they're eating very inconsistently. And that's not great for balancing your blood sugars. So simply getting on a consistent kind of eating plan, and maybe, making sure you're drinking water and exercising, for one person, that might be enough to prevent gestational diabetes. And
Mm-hmm.
for somebody else, maybe they have PCOS and a family history and they're 40 years old and some of these other risk factors, and they do all of those things, they still might not be able to prevent it. But my thought is to start as early as possible. If you have risk factors, especially, or if you've had a past gestational diabetic pregnancy, is to start with balanced nutrition and some of these other lifestyle factors that help blood sugars stay balanced. Start as early as you can, even preconception if possible, because
Mm-hmm.
maybe you are that person that it can't, just getting those things in line can prevent it. And if
Right.
not, it's always going to help you manage and just keep things much healthier with better outcomes when it's managed versus not.
Mm-hmm. I love that answer because there is so much nuance in it. But like getting the blood sugars balanced is also going to help with like nausea in the first trimester. It's going to help with
Yep.
like so many other potentially things.
Yeah.
But the problem is we're not given any of that information. So I had said on a podcast a while ago, like, when I had gone to an OB here right before my husband and I got married, I'm like, we're probably going to try it for a kid in the next year. And he's like, cool, great. There was zero information. There was anything like, great, like here's some things that you can do to make sure that you're getting in folate and choline and all these vital nutrients that your baby needs to grow, that your body needs for a healthy pregnancy.
Mhm.
Um, Nothing. And then even at your first prenatal appointment, a lot of times here where I live in Illinois, they're not seeing you. It seems like for some reason, every single person I know, like every single clinic is so busy and packed, and like you don't get in until between 10 and 12 weeks now
Mhm.
at a lot of places. You might be seen closer to 8 to 10, but a lot of times, I mean, let's just say 8 to 12 weeks. So you're already well into your first trimester. And so you
Yeah.
have nobody guiding you. You have nobody setting you up. You're already in that. You're already in full swing of the nausea. You're already in full swing of other things, just trying to
Mhm.
survive. And there's no like, I wish there was even like when you call to make that appointment that they're like, great, we're going to email you over some information. Please read through this. You don't have to be in there, but at least give the people something,
Yeah.
and so that's like the unfortunate thing is because if you are that person that maybe those changes would prevent that, you're not getting
Mhm.
that information. So that's why I love having these conversations too. But it's frustrating, on
So
this end
frustrating.
being like, come on, let's help people help
Yeah.
themselves and like get this information out there.
Yeah, I mean, I will even say it's a bigger issue than in the OBGYN world. It's everything. Our healthcare system is set up
Yeah,
to treat disease and syndromes versus prevent or educate.
right.
And I wish there was a dietitian in every doctor's office, from pediatrics to OBGYNs to general practitioners, because it would help so much.
Hmm.
And even like what you're saying of, that first call, they're like, okay, we'll send you some stuff. If they don't have a dietitian in house that you can talk to, fine, we'll send you some things. Um, but also, wouldn't it be nice at that first appointment that they shared with you, okay, pregnancy can bring on a lot of different symptoms and different issues, but let's just, even if they don't have the time to chat through it, like here's a list of some things that are like common, maybe, or that you could expect possibly down the road. Nausea, vomiting, hyperemesis, it could get to that point, or blood pressures might go up, and talk about preeclampsia and gestational diabetes, and how we can manage these things and you can still have a healthy pregnancy. But
Yeah.
if it's never talked about until you're taking the test, that's very scary. So
Right.
like
And
the
then you're getting this test saying that you have it, and you're like, oh my gosh, like, what did I do? Was there something I could have
Mhm.
done? But also, what does this mean now? What does this
Yeah.
mean for me, for my pregnancy, for my birth? Um, So I'd love to maybe talk about that a little bit, because I know as soon as a client or somebody reaches out to me on Instagram or a friend or somebody, they're like, I have gestational diabetes, and I already know exactly what the provider's going to say. I'm like, they're going to want to induce you at 38 weeks. They're going to tell you that you have a big baby. You're going to have to go to maternal fetal monitoring every week toward the end. You don't have to. This is what they're going to tell you to do.
Yeah.
Um, but here's the research, and I give them the evidence-based birth handout about it. And it seems like the way that the information is presented to them is that they are this huge risk. They are a huge high risk mom now, and we have to do these precautions to keep you and baby safe.
Mhm.
Does gestational diabetes really make you high risk?
So I would say that it is high risk in the sense that it does require extra monitoring. And I do like the extra monitoring and I know everyone feels kind of different about ultrasounds and things like that, but I do think growth scans and ultrasounds are helpful for gestational diabetes specifically because when you're checking your blood sugars at home, they're minimum 28 times in a week, 4 times a day, a
Jeez.
lot.
Yeah.
And not every one of those numbers has to be perfect in order for you to have good outcomes with your pregnancy and delivery and a healthy baby. So, but it's hard when you're in it and you're looking at every number and analyzing everything you eat and every number. It's hard not to stress about a high number. So, those ultrasounds or growth scans, if you can go to those and say, oh, baby's measuring perfectly. My fluid levels are great. Like placenta looks awesome. And everything looks good on that growth scan. I think it's nice to put that in perspective of your numbers. So that's telling me that your numbers here, couple high numbers sprinkled throughout the week, are not impacting the baby's overall growth. And I feel like that gives moms a real good peace of mind to
Yeah.
know where they're at. And on the flip side too, like if their fluid levels are high, the baby's abdominal circumference is measuring out of proportion, or the baby's overall size is measuring bigger, those are things with time and blood sugar management that can come back down within normal range. So it's important to know those markers, I think.
My only issue with the growth scans is that like 1 in 10 are told that they have a big baby when only 1 in 3 do. And just like
Right.
the accuracy, and like once it's marked in your chart that you have a big baby, you're more likely to have a cesarean birth. So like that's my hesitation with it, of like, and the mental thing. Like if you're being told you have a big baby, then you mentally are like, crap, can I birth my baby? Like,
Yes.
whereas like you can. Um, so that's like my like hesitation around it, is just like the stigmas that come around having a big baby, and how basically now in the hospital system you're treated as high risk just from an ultrasound saying that you have a big baby, when we've been built to birth our babies, and that doesn't necessarily like mean anything, you
Yes,
know?
I agree with you. And really the issue, because like you said, women are built to birth big babies. The issue that really is concerning is shoulder dystocia, and we know that that is more about fat buildup. So with
Hmm.
gestational diabetic babies, they have a higher incidence of depositing their fat stores in different places than a baby
Yeah.
without gestational diabetes. And then that can become troublesome at delivery if they have shoulder dystocia. But ultrasounds and growth scans don't pick up on fat stores. So that is an issue.
Hmm.
But I think, going in to be monitored, like if you're on insulin, you'll be going in for non-stress tests. For some women, because I was just asked this the other day, for some women who are well managed, all of that extra stuff can be a little bit overboard, in my opinion.
Yeah.
But some women really do truly need it to make sure that they are safe and baby's healthy.
Hmm.
Um, so again, this is where I feel like patient-centered care is
Right.
so important, but we're so lacking in it. So if
Right.
they were to look and say, "Oh, Leslie, like your numbers are great, everything looks great. The last ultrasound you had, everything was great," maybe you don't need another one if it's something like as a source of anxiety, or you just don't feel like you want to come in for it. Great, so they're not putting you in those boxes, because you're right. What they're doing is they're saying you have gestational diabetes, you'll be induced. You have a big baby, you'll be induced. Like you're on insulin, it means this. It's just goes down a checklist, I feel like. with the
Right,
day.
right. Well, and that's where, like you said, just kind of like the care. And that's why I love having these conversations because for some people, you might need that, but for some, not. So, like my client last year, her fasting numbers were great. And she went to like her first ultrasound and baby looked great and then decided not to go to the rest because they started pressuring her for induction. And, she had a 7-pound baby at 40 weeks and on her own, went into labor on her own, waited for her body. But she didn't need insulin. She didn't need any additional help. So like I've actually never had a client who had to be on insulin during delivery. So I'd love to kind of like learn a little bit from you about that. So like what does that look like if let's say your numbers aren't managed solely through diet? Do you know like about what percentage of people like might need insulin?
That is a good question. I actually don't know the overall percentage,
Yeah.
but that would be interesting to know. Usually, what I will say is usually insulin for the majority of people is introduced to help lower the fasting blood sugar. It's
Right.
not as common that women are on it throughout the day for their meals. Usually, meal numbers are pretty well controlled. It's that fasting number that's such a struggle. And that's for different reasons, but the placental hormones are higher in the morning. So it just
Mm-hmm.
makes that number more challenging. And so once they're on insulin, they do require more non-stress tests. They will probably get more ultrasounds and growth scans. And then delivery, I hear that too with induction, especially once they're on insulin. But it really just depends on the provider. And it
Right.
also depends on how well you're advocating for yourself, because I think that's huge.
Mm-hmm.
I tell all of my clients, ask for the research, ask why. You can say no to things. I'm not a doula, I'm not in the birth education space, but I love what work you do. So it's like, I try to pass on these little tidbits of like, use the BRAIN acronym,
Right.
and your opinion matters and your gut matters. It is your decision at the end of the day. And some women are more comfortable with risk, some are not. So it's all so individualized.
Mm-hmm. Right. Yeah, that's why usually I'll attach in the show notes the evidence-based birth. Um, I love them. They're like one of my go-to sources, their thing on gestational diabetes, because that's like one thing I always say, like for some people, so shoulder dystocia is increased with larger babies, and one of the risk factors for a larger baby is gestational diabetes. Um, However, all providers should be well versed in how to handle that. Um, if they are not, like that's an issue, and just because you are at a higher risk for a shoulder dystocia doesn't mean you necessarily have to have a cesarean. But in the event of birth, if it comes to that, like having the information is so vital, and having the research and knowing maybe what might make that risk greater and what might not. And then you are the decider of, oh, wow, like I don't know the exact percentages off my head right now, but like 2%, that sounds like a lot. Like I don't want to take that risk. Or, oh, 2% doesn't sound like a lot. Like I have no problem trying this. So
Right.
each person, but that's why you need to have the information and make those decisions for yourself versus the provider just putting you into this category, um,
Yes.
and everybody being treated the same, even though every
Hmm.
single case is not the same. So
Yep.
that's the hard part with this, and that we're all
Hmm.
like learning too. Because like I said, I don't know a lot about gestational diabetes. Maybe there are some, like obviously, like my client that I had, her morning fasting numbers were great. Like she was great. She didn't need insulin. She had it under control. Was able to manage it with diet and movement, but that's not everybody's case. So
Right.
in the other cases, do we need more intervention? Do we need more precaution? Do you need more monitoring? Um, Maybe, like I
Yeah.
don't know a lot. That's why I'm learning from you.
Yeah.
Um, some cases, I mean, what happens if like you're okay, so here's like another scenario, because you can say yes or no to anything. Let's say somebody declines getting tested for gestational diabetes and they have it. Like, what are the potential risks that having unregulated insulin could have on your pregnancy?
So if you decide not to get screened, which I do not recommend, then having uncontrolled blood sugars in pregnancy can lead to, like we said, bigger baby, shoulder dystocia, respiratory distress, low blood sugars at delivery, stillbirth is something that it can lead to, but again, rare. So I don't want to say that to scare people, but it would not be great advice to not be screened. And I would highly recommend to be on top of your blood sugars during pregnancy if you are testing high, because uncontrolled blood sugars can definitely have an effect on the baby post delivery.
Yeah. Um, so let's talk like a little bit about the diet stuff. Because I think that that's a piece that's also kind of left out is if you haven't gone through it, you don't understand it. And
Hmm.
there's a huge diet piece of this. Like now that you've been diagnosed, you can't just go out to dinner and order whatever you want anymore. Is that true or not? Did I just make that up?
So, well, I guess it depends on what you usually order.
Yeah, yeah.
So my method is very flexible. I want all foods to fit. I would rather see what you're eating and tell you how to adjust it to make it more blood sugar friendly. And most times that's all we're doing. I don't believe in strict diet plans. I don't believe in restriction. The most common thing you'll hear is restriction. You can't eat
Mhm.
carbs, you can't eat pasta, you can't eat out, you can't do all of this stuff. Sweet treats, forget about it. But you can. It just matters how you eat those things.
Yeah.
So the portion of carb that you're eating matters. How much carb at that meal or snack matters. And then having protein and fat and fiber in that meal to balance that carb also matters. So what I do all the time with my clients is, I actually have a whole module on how to eat out with blood sugar balance, but also if they're going to a restaurant and they send me the website and we go through the menu and I help them navigate it. And more
Nice.
often than not, they're ordering the same thing that they would get if they did not have gestational diabetes. We're just knowing how to order it. So it might be, oh, just add a salad to that for fiber. Or, okay, if you're going to do pasta, you just want to do like a smaller portion than what they're going to give you, but you can still enjoy it.
Yeah, but most people don't have you in their ear telling them this. So like what I've heard from like a lot of people is like, man, I just like miss eating carbs, or I can't wait to have the
Mhm.
baby so I can have a scoop of ice cream, or like they're kind of told, okay, you have gestational diabetes, now you can't eat carbs, you can't eat sweets, and that's it. So they're like living on cottage cheese and beef sticks, you know?
Yeah. So I would not recommend to cut out carbs. Actually, your body needs them. In pregnancy, in the second trimester, you need an additional about 340 calories in a day. And if you take out carbs, you're also taking out calories and nutrients that are important. In the third trimester, you need about an extra 450 calories a day. So your body is doing a lot in pregnancy,
Yeah.
right? I always say to women, like, if you're not pregnant, and you're doing kind of this low carb, it might not be as big a deal for your blood sugars, but in pregnancy, it really is, because your body is in an extra high demand for calories. You have a higher need for calories across the board and carbohydrates. So taking them out, not great for baby, not great for blood sugars, probably not good for mood either.
Right,
I
right.
mean, we're going to be hungry without that kind of stuff.
hmm Um, so like I said, like unless you've gone through it, you don't really know. Like with so many things, like women who deal with hyperemesis or extreme nausea, and that they're just told like, yeah, that sucks. That's just like a part of pregnancy. But like unless you've experienced that, like you have no idea. And like the same goes for any risk that comes up. And I'd love for you to just to kind of speak to the mental load that kind of comes with being a gestational diabetes mom, and maybe some of the stress. And I'm sure that that depends again on like provider to provider, like how
Yeah.
they're treating you at appointments,
Yep.
and making you feel. But yeah, that just kind of that mental load that comes with it.
Yeah, and it's a lot. So with the diagnosis, like I mentioned, they're checking their blood sugars 28 times in a week, sometimes more. If they're taking insulin, they might have to be checking their blood sugar more than that. So that's constantly thinking about checking your blood sugar. And then you're worried about what to eat. When's the next time I have to eat? Do I have a protein to pair with this? Oh shoot, we're going out of town this weekend. What am I going to do for that? I mean, it's just pretty much a loop always in your mind. So it is overwhelming. I recommend clients find some tools, some healthy tools to cope with stress because it is a big deal and it is a lot. I think I'm a big fan of meditation, journaling, walking out in nature, yoga, podcasts.
Mm-hmm.
It's going to be different for each individual person, but I stress it all the time to my clients to find some outlet for that mental load of it because it is a lot. And you're right, it does depend on your provider. So if you have an understanding provider who's reassuring you, that is
Yeah.
really great. If you don't, then I think leaning in on that and finding support, whether it is from a doula or a dietitian, whatever it is that you're stressing about, like, is this going to change my birth plan? And I tell all the time, connect with a doula because you'll know your rights and you'll know how to advocate for yourself. So I think it's really finding what is the piece that's stressing you out so much. Is it what and how to eat? Connect with a dietitian. Um, I think that is huge. I've also recommended to clients too, if it's really weighing heavy on their mental health, take a break from testing your blood sugars because that constant thinking about it, just taking a day off or a weekend off, most providers are totally fine with it, but it just allows you to kind of reset, to just get a day back where you're not constantly thinking about numbers. But yeah,
Yeah.
the mental load is huge.
Mm-hmm. Right. And like, yeah, kind of revolving your life around that. Like when you have to test and like, I feel like the snacking is hard because you always have to have something prepared that you can grab. And even like I struggle with that now. Like I've been trying to like make sure I have go-to snacks in my fridge for like me and my husband and my kids, because otherwise you just like turn to
Yeah.
something else, and it's like it's nice if the vegetables are already cut up and the fruit's washed and ready to grab. And um, like I've been just I've been making a menu each week, and I have like a couple of snacks that I put on the menu that I make, and they're just like in the fridge and easy to grab because I'm like, otherwise, it's so stressful. It's so
Yeah.
stress. And I just started doing that like the last couple of weeks because I'm like, I hate opening the fridge and being like, oh, I have to make that. I
Yeah.
don't want to make
Yeah.
that.
Yeah. And like this thing with motherhood, I mean, women are just, we're already stressed
Hmm.
out, whether you have little kids already or not, like work and life and just the pressure of so much that pregnancy we shouldn't have to do and figure out alone, especially with the added stress of blood sugars now and what to eat and how to eat and why is my fasting high and trying to figure all that out. And trying to figure out what I need to ask my doctor and how is this going to change my birth. And we shouldn't have to do it alone. So support, it will help your stress levels
Yeah.
so much. Might not be
Mhm.
perfect, but it will help a lot.
Yeah. And I think just also being equipped, like knowing that there are resources out there. I know like
Mhm.
your account you give out tons and tons of amazing content. Um, and I know that there's people out there that you can find information and know that you're not alone and get tips and feel equipped to deal with it because yeah, it sounds like a lot. um,
Yeah.
but also like you said at the beginning, like it's so important to know that like or to not like beat yourself up about it. And you had posted something the other day that I loved, and you said like you are not your diagnosis. And I think that that's like really, really important with so many things that come, not just gestational diabetes, but any of the factors that like pop up for you, maybe in pregnancy or
Mhm.
birth, how your birth goes, in motherhood. Like it's
Mhm.
this
Yeah.
like season of life of learning, I feel like pregnancy is like your introduction to like parenthood of like, hey, you have no control over
Yep.
anything that happens. Like, you don't know what's going to happen to this baby. You don't know what's going to happen in your birth. You don't know, like, then you
Mhm.
have these like little kids that are, we're not meant to control them. We're meant to guide them. But it's just like that
Yeah.
introduction into like, oh, wow, I have no control as a parent. I have no
Yep.
control, like in your pregnancy, like just even the normal anxieties that come with it of,
Mhm.
is the baby okay? Is everything going, we don't know what's going on inside.
Right.
So there's so much like trust and faith that like comes through it. And it's just kind of like that introduction. So when there's just the added stresses on there, it's like just next level, and it's hard to like not take blame and just to know that you're not defined by this.
Right.
Um, and it doesn't make you a bad mom, and it doesn't lead into that next stage of your life. And I think knowing that you have some control, so whether it's in your birthing plan or with your diet, like that helps
Mhm.
kind of take back some of that power and know that
Yeah.
you aren't defined by that diagnosis.
Yes. Knowledge is power. And then all of the other things that you can't control have to let go. And I love what you said because I tell my moms that all the time. Like, this is really setting you up for especially postpartum and motherhood in general, because the challenges will always be there with kiddos. I mean, it'll change, but there's always something to worry about or think about or challenge us. And so, yeah, I love that if we can think of like gestational diabetes almost even as a silver lining
Hmm.
of, oh gosh, I really was not drinking a lot of water before, and this opened my eyes to how important that is. So now I'm going to do that and carry that through postpartum, then that's a win.
Yeah.
Or, it doesn't always have to be about blood sugar numbers. It could be, I feel like I have so much more energy now that I've added carb back into my diet, and that's amazing. And oh, I didn't know that before. I'm going to keep doing that after I have the baby. So I think there's so much to take away from it too. But it's a lesson, you know.
Hmm. Yeah, I love that. So for people listening, how can they work with you?
Yeah, so you can find me always on Instagram. I'm at Gestational Diabetes Nutrition. I also have a website, it's gdmnutrition.com. And I have a one-on-one group coaching program where you get lots of personalized support. And then I also have a self-paced course. Sometimes I do like single sessions. So lots of different options to work together.
Awesome. And then, yeah, where can people find and follow you? You just gave the Instagram. I'll link that in the show notes. So it'll be really easy for people to find you. And I just want to thank you so much, Leslie, for coming on the podcast. I feel like I'm sure there's so many more things that we can dive into. Um, but I think it's great just to give women information just even beforehand, because it's not something that you think about before you get pregnant. And even when you get pregnant, you're not thinking, oh, I'm gonna have gestational diabetes.
Right.
Um, and I mean, every pregnancy I've been nervous. Like when I go for my test, I'm like, oh, like I hope I don't,
Yeah.
but there is that like, have I been doing everything right? Da, da, da. And it's not always about that. So I think that
Right.
these conversations are really good, really empowering, just even to get that information before you even have kids. Like you said, kind of like learning to balance blood sugars, maybe that you are that person. But even if you do get diagnosed, knowing that there's options, that there's answers, and that there's a whole community of women out there who have been through it and who can help you through it. So I just want to
Yes.
thank you so much for coming on the podcast and sharing all of your expertise with us today.
You're welcome. Thank you for having me.